Access to Democracy is made possible by donations from the following organizations. Thomson Reuters, a global company with expertise and insight to unravel complex situations in the areas of law, tax, compliance, government, and media. Their worldwide network of journalists and editors keep customers up to speed on relevant global events. Thomson Reuters, the answer company. The division championship Minnesota Twins are looking to go all the way to the World Series in 2024. Bolstered by inspirational shortstop Carlos Correa, a healthy Brian Buxton, and rookie phenom Royce Lewis, plus a pitching staff led by Pablo Lopez and an outstanding bullpen featuring Johan Duran, the Twins are the best bargain in the major leagues, and Target Field is the best venue in baseball. Sheridan Dulas & Kins, PA, a family and criminal defense law firm, has been serving clients in Dakota County and throughout Minnesota for over 40 years. Ranked a Tier 1 Best Law Firm by U.S. News & World Report every year since 2009, Sheridan Dulas & Kins are here to help you in your most difficult life circumstances. Established in 2007, 45th Parallel Spirits was among the first 50 micro-distilleries in the United States. Based in New Richmond, Wisconsin, all aspects of production occur at our facility. If you're interested in visiting and learning more about the 45th Parallel Distillery, please check our website and plan a visit to tour our facility and taste our spirits. Truestone Financial, with locations in Minnesota and Wisconsin, has proudly served its members since 1939. Truestone engages, educates, and supports its members to ensure they have the tools to empower their financial well-being. Truestone Financial, your neighborhood credit union. Learn more at truestone.org.
Hello and welcome to another edition of Access to Democracy. I'm your host, Steve Francisco. It's a pleasure to welcome to our studio today a good friend of mine. He's making his second return visit to Access to Democracy, Hunter Cantrell. Some of you may recognize Hunter. He served one term in the Minnesota Legislature, and more recently, he is a second-year student at the University of Minnesota Medical School. Hunter, welcome back to Access to Democracy.
Thank you so much, Steve. It's a pleasure to join you once more. I'm a huge fan of the program, and I'm excited to talk with you again, as always.
Good to have you here. So today we're going to talk, give our viewers a little bit about your background. They may not have seen your first appearance here. Tell us where you grew up and where you went to school.
Yeah, so I grew up most of my life in Savage, Minnesota, but I've also at times, especially when we first moved here, lived in Burnsville. And so, I'm a Savage, Burnsville guy.
You're a South Metro guy.
Absolutely, and graduated from the proud product of the ISD 191 school district and graduated from Burnsville High School 2013. Went to University of Minnesota for undergrad, and now I'm very grateful to be a second-year medical student at the U of M Twin Cities.
Excellent. In 2017, you went through a rather serious healthcare challenge.
That's right.
Tell us about that, and the reason I don't normally ask people about these types of things, but you're willing to talk about it, I know, because it actually was a turning point for you in what you subsequently did. Tell us about what happened.
Yeah, so when I was 21 years old in May of 2017, I was diagnosed with stage 2 Hodgkins lymphoma, and that started a very challenging journey. And I know that you were there for me throughout much of that. And kind of through that, it was also over the backdrop of a Republican-controlled U.S. House and U.S. Senate, as well as President Trump in the White House. And they were working to repeal the Affordable Care Act while I was actively undergoing chemotherapy. And, to me, that really set into focus kind of my life's mission, both in terms of an advocate, somebody who, at the time was aspiring to eventually make it to medical school someday, but knowing that there are so many vulnerable people in our state and throughout our country who don't have the basic protections and the basic access to health care that saved my life. And so that prompted me really to do a lot of soul searching. And, after I was hospitalized for 10 days, almost towards the end of my chemotherapy regimen in October of 2017, I made the choice to, if nothing else, to be an advocate for people who were struggling and to be an advocate for working class people who didn't have the health healthcare access and healthcare stability that I had, and chose to start my campaign for the Minnesota House of Representatives while I was still going through chemotherapy.
Which you won.
That's true, yes.
In a district that had been considered a reliably Republican district.
Yeah.
Yeah, in Savage, Shakopee area.
Yep, that's true.
And you won the seat. And so what issues were you particularly focused in? I assume you're going to say healthcare. That was one of the key issues. What other types of issues did you champion during your time in the legislature?
Yeah, so I was, at the time, the only out gay member of the Minnesota House of Representatives. And so I was a passionate advocate for banning the roundly discredited and very harmful practice of conversion therapy in Minnesota. And so conversion therapy, for people who don't know, is a very harmful, it's not even really therapy. It's meant to try and change somebody's sexual orientation, which we know from all of the scientific and medical literature, just that's not possible. The best way to help somebody navigate through challenging feelings, if they have any about their sexual orientation, is through affirmation and through kind of helping them in a way that is actually consistent with best practice for therapeutic intervention.
And wasn't the issue of the conversion therapy, as I recall seeing legislative testimony on this too, a lot of it was based on junk science or false science.
Right. That's true. And so, I'm very grateful to Representative Athena Hollins and Senator Scott Dibble for passing that bill in the last biennium. But in addition to that, I care so much about making sure that Minnesotans with disabilities and their families, especially, are not left behind in the policy decisions that we make in Minnesota. So, I worked to make sure that we had a more equitable workforce access for folks with disabilities. When the COVID pandemic broke out, I led the passage of a $30 million bill to make sure that we stabilize the day services resources for folks with disabilities so that they wouldn't lose this vital lifeline as the pandemic unfolded and then, when the pandemic resolved. So, the core philosophy that I bring to my practice of medicine, my advocacy, and to my work in the legislature is, we need to fight for the working class. We need to fight for people who don't have, who don't have a seat at the table, and that means folks who are homeless, folks who are living with disabilities. Like I've always just believed we can't leave them behind. We can't leave anybody behind. So that was really at the core of everything that I did in the Minnesota legislature.
When you were talking about the circumstance in 2017 when you had been diagnosed with cancer, you were undergoing treatment, and it led you down this path toward public service and running for elective office. You mentioned that President Trump was in his first term. Mm-hmm. It's Groundhog Day again. The former president will be the president-elect. He will take office in January 20th. There are suggestions that he is still looking to reform or repeal so-called Obamacare, the Affordable Care Act.
Right.
What are your thoughts about that as we went through this struggle before, and we have the late Senator John McCain to thank for having defeated that effort to repeal that legislation, which provided health insurance to 32 million Americans. What are your thoughts as we look forward to a second Trump presidency? What could happen with health care?
Absolutely. I think everything is up in the air. Certainly the composition of the U.S. Senate has changed quite a bit since Senator John McCain made that courageous vote against his own party to halt the repeal of the Affordable Care Act without a suitable replacement. So it's hard to tell because I feel as though repealing the Affordable Care Act wasn't as front and center of President-elect Trump's campaign this time around. And I think that's because they know how unpopular
But it was mentioned in Project 2025.
Right.
Which the president and some of his supporters say, we really don't know much about that, even though the people who drafted Project 2025 served in his first administration.
Absolutely. I mean, we know that Project 2025 is the Trump agenda, is what he, or at least the people around him, are going to try to advance. And so
you expect they'll make an effort again to try to repeal it?
Yes, I wouldn't be surprised. They've always tried to offer quote unquote alternatives. And don't get me wrong, right? The Affordable Care Act was a groundbreaking piece of legislation.
It's not perfect.
But it's not perfect, right? And so I think that we can always strive to make better improvements to sustainable access to health care, lowering the cost of prescription drugs. And I think that President Biden and the Democrats in Washington and in Minnesota here have worked very hard on that.
What's always struck me as very ironic, Hunter, is that people on the Republican side mischaracterized Obamacare, calling it socialist medicine.
Right.
In fact, it still relied primarily on the private sector insurance companies to give people access to health care. And when you talk to people about what their concerns are, understandably, they're concerned about skyrocketing premiums, about the increasing costs of prescription drugs, but that's not all attributable to the Affordable Care Act. Right. I've always wondered, for example, why is it that every health insurance company has a different form? Why can't they standardize the form and try to curtail some of the cost of just the bureaucratic paperwork side of delivering health care to people, which could result in tremendous savings?
Absolutely, and I think that is one of the most concerning outstanding aspects of healthcare policy that have yet to be addressed and resolved is there has been a tremendous amount of administrative load, whether we're looking at our hospitals or we're looking at insurance companies, that not only do they have opaque financials, but they have all of these administrative costs that result in our premiums going up for unknown reasons that don't feed back into our ability to get better care, to get more affordable care. Yet premiums go up year after year, deductibles go up year after year.
So people are right to be worried about these price increases.
Absolutely.
But it's probably the wrong approach to say that the solution is to kick 32 million people off from health care.
Absolutely. I mean, I think about everyone who has a pre-existing condition, which is a lot of people, probably over 100 million Americans, if not more. Myself as a cancer survivor, I worry about my continued access to health care, and I'm in medical school. Mm-hmm. But I'm not alone. There's so many people who, regardless of their partisan leanings, need access to health care, especially to cover pre-existing conditions and life-saving medications. And we just need to keep, at least in Minnesota, continuing to work with the tools that we have to make sure that Minnesotans are able to access their health care needs.
So you did something really extraordinary, Hunter. After a hard-fought campaign and a very productive term in the legislature, you stepped away. Mm-hmm. And I hope temporarily, you and I have talked about this, I have great aspirations for you in the future, perhaps a return to elective office at some point. But you made the very conscious decision to decide to focus on your education and go to medical school. Tell our viewers, what's it like to be a medical student? Give us a view of what is a typical week for Hunter like as a second-year medical student at the University of Minnesota.
Absolutely. I first and foremost, the University of Minnesota is a fantastic medical school. We have access to world-class faculty, and my colleagues are incredibly bright. So people can rest assured that in Minnesota, especially since the U of M trains 70% of the doctors here in our state, is in good hands for the long term in terms of their healthcare services and healthcare providers. But in a given week, I'm studying several hours a day. We frequently have very complex exams. I spend quite a bit of time in clinic and doing research. And so, what a lot of people might not know is that for a lot of the competitive specialties in terms of residency matching, the top being dermatology, which people are always surprised about, plastic surgery, neurosurgery, so on and so forth, you really need to have, by the time you are applying to residency, at least 20 to 25 publications and presentations and abstracts that you have authored, if not first authored, contributed significantly to in order to be competitive for a lot of these specialties.
That's very interesting. Mm-hmm. And I think you had told me at some point in between now and last year that many of your classes or tests you do online.
Yeah,
so it's unlike the way in the old days, if you were a medical school student, you had to show up in person for every single class. That's not necessarily true anymore, is it? You do online learning and online labs or testing?
Yeah, absolutely. And I think it's made medical school more accessible to people and certainly more humane. We think about the old school of medicine where it was hyper competitive, and we don't want that in medicine. You don't want your doctors, when they're practicing, to be competitive with one another. You want them to, work alongside you and work with their colleagues so that they can figure out what
I want
your
my
needs
doctor
are.
to be my advocate.
Exactly.
Not worried about what another doctor is doing.
Right. And so really, I don't know if I can speak for all medical schools, but at least for the University of Minnesota Medical School, has really taken great strides, I think, to diminish that historic precedent of competition and undercutting and things like that that had been mainstays of medical education in the past and maybe at other institutions, and really fosters an environment of cooperativity. So we all work to share research and knowledge with each other and to help each other perform as well as we can and have access to the opportunities that we know just better us as providers and better our world.
That's really great. It seems that we are in the midst of a transformational time in history. We are living through the so-called AI revolution, artificial intelligence. Do you have any thoughts about how artificial intelligence is changing the study of medicine and the practice of medicine in the future?
Yeah, absolutely. The field of AI is so nascent that I don't think we have even began to assess the impact that it's going to have on medicine and in the world as a whole. Where my concern comes from with AI, and I think we've already seen this with certain health insurers, is using AI to automatically deny patients prior authorization.
Profiling people. Profiling patients.
Yep. And there was a large health insurer that got in trouble for that recently here in Minnesota. And, so I worry about these tools being used to make healthcare more expensive for people and less accessible to people in a system that's already structured for that to be the default. So, what I really want to see is, I think AI can be helpful, especially when assessing all these different moving parts that go into making, particularly the more complicated medical diagnoses, when you're pulling in lab values and patient history and family history and imaging, right? AI can be a tool to help us synthesize a lot of that information and see where we're missing, right? Because we're all human. And so I'm interested to see how that will help improve patient outcomes and improve healthcare. What I always worry about is how will AI be used to profile people or make arbitrary decisions and not have human oversight, particularly when it comes to the financial decisions of health insurance companies, which certainly don't have our best interest in mind most of the time.
No, they're interested in making money.
Yeah.
It's very interesting that what you're talking about right here seems to really highlight this intersection of science and public policy. And it seems as if our legislature and Congress may be a few steps behind how fast the science is advancing, artificial intelligence. And like social media too, it seems it's one of those areas where there are a lot of good things that can be done with this, but there are also some things we need to be very alert to, and where we're going to count on public policy makers to make the right decisions to protect the public interest.
Right, absolutely. And I think a big overarching concern with AI is not just the how sophisticated it's becoming in the sense of producing content that is portrayed as being made by humans on social media. Anyone who spent any amount of time on any of the major social media platforms knows that there's just so much AI-generated content, and it's really challenging now to figure out that line of, is this generated by AI or is this generated by a human being? Or, are you talking to AI or are you talking to a human being? I think what we see is, the public sentiment, at least as it stands right now, is most everybody prefers to interact with human beings. And whether it's, online or if it's calling a restaurant to make a reservation, people want to talk to other people, right? And so the other issue with AI too is, and we've seen a little bit of this with cryptocurrency and things like that, is the environmental impact of the energy consumption that's required in order to power AI. It's 75 to 80 degrees out today, and here we are in November in Minnesota. So, I think we are currently experiencing the climate crisis, and I am worried, and I think a lot of other people are worried too, about the lack of environmental sustainability with these expanding technologies and the lack of focus, I would say, on reducing the carbon footprint of these technologies that are developing.
Interesting. It's interesting that my primary care physician told me something during my annual physical with him this year, and it really kind of concerned me. He said, the bean counters, he calls them, the people at M Health Fairview, and this is true of any healthcare company in Minnesota. We have several of them. He said they're monitoring him very closely. They're monitoring how much time he spends with patients, how many interaction, and the emphasis is don't spend too much time. Don't spend too much time there because you need to see other patients so that we maintain productivity, if you
Yeah.
will, in terms of how many patients doctors are interacting with on any given day, and that they're thinking about the impact on the bottom line. And I think everyone gets the idea that businesses won't stay in business if they don't maintain some concern about the bottom line. But it runs into this problem of people who are non-physicians making decisions that affect our health care.
Right.
And you share that concern, I'm sure.
Oh, absolutely. Absolutely. I think over the past 20 to 30 years, it was certainly accelerated in the last 15 to 20, we have seen the practice of medicine slowly be taken away from being physician-led to instead being led by people who have absolutely no experience treating patients, helping patients, providing health care. And that is to the detriment of everybody's well-being. When we have people who are more concerned about the bottom line, who have absolutely no understanding or exposure to clinical practice, running hospital systems, running the fundamental mechanisms of care, that ends up harming patients and resulting in worse outcomes in the long term.
We've seen just some really significant structural changes in recent years. You know, there was a time when there were a fair number of independent practices.
Right.
My wife used to work at one, independent medical practices. Hers was in neurosurgery. There are others, the different specialties. But you're seeing fewer and fewer independent practices able to exist because of economic factors and pressures that they're facing financially. So, you know, it's how are they going to disappear completely, do you think? Or is it going to be possible that there still will be some independent practices that are separate from the major healthcare systems?
Yeah, absolutely. And this really touches on an important through point that I don't know necessarily rises to the top in a lot of health policy discourse conversations, but the consolidation of medicine to a corporate large-scale conglomerate model, one, I mean, results in higher costs for patients because of functional monopolies that are created in the healthcare ecosystem. But also, you know, independent physician practices that are able to practice medicine in a way that they know is most consistent with the essence and the spirit of good medical care are a vital asset to our communities and to serving people. So we certainly need to continue to work towards making it more viable for these independent practices to continue serving our communities and serving their patients without having to be swallowed up into either large healthcare conglomerates or what is almost more of a concern for me, being functionally acquired by private equity firms who really, truthfully, have solely their shareholders in mind when they're structuring how the practice operates. Now in Minnesota, we have what's called a corporate practice of medicine doctrine, but viewers should know that our corporate practice of medicine doctrine isn't something that's explicitly enshrined in law. It's a patchwork of a couple of laws and regulations here and there, but is really reliant on 2 Minnesota State Supreme Court cases from the 1900s. So we have this patchwork that hasn't evolved to meet the modern framework in which healthcare acquisitions are happening in the state of Minnesota. And these private equity firms, you know, they really spell, by and large, you know, not everyone's the same, but by and large, the data is showing result in worse patient outcomes, worse working conditions for physicians, nurses, and anyone else involved in healthcare, and, you know, ultimately drives up costs for patients across the board.
I assume that there's some regulatory process here when you have these types of things, that there has to be some sort of state review. Are the laws in Minnesota, do you believe they're adequate to deal with these types of this type of regulatory oversight of what's happening with healthcare consolidations?
Yeah, you know, so I think that the DFL trifecta worked very hard over this last biennium and the DFL House before that to strengthen our regulatory apparatus to ensure that patients' needs are centered first and foremost in considering authorization or mergers of especially large hospital systems. But, you know, there's always more improvement that needs to happen to ensure that these hospitals, many of which are, I think all of which except maybe one in Minnesota are nonprofits, are truly living up to the missions that status confers to them, and that is to serve the public, you know, rather than for financial gain of these systems. So I would say, especially on the private equity healthcare front, we need to do a lot more work in Minnesota to make sure that especially the more predatory actors in the private equity firm ecosystem and real estate investment trust ecosystem are not unfairly operating, engaging in geographic consolidation of medical services, which is a common mainstay in private equity acquisitions, but fundamentally that the needs of patients are first and foremost.
I want to ask you about another aspect of healthcare if I may, Hunter, and that is we continue to see really dramatic disparities in Minnesota. We love to pat ourselves on the back, say we're home to the U of M hospital system, the Mayo Clinic. We have great health care, and I always say you have great health care if you can afford it and it's accessible. There are big disparities in our state for communities of color, for indigenous people here in Minnesota.
Absolutely.
People from different nationalities and racial groups here in our state. What do you think can be done to try to narrow some of those disparities in the delivery of healthcare services, which have an impact on things such as child nutrition, infant mortality rates, a whole range of things?
Absolutely, and I think this is an extremely important question. There's certainly still a lot of structural racism embedded into the practice of medicine and how our healthcare systems are organized and structured. I mean, we think about the just dearth of access to care that people across the board have, but especially people from marginalized communities have in Minnesota and in other states as well. But just focusing on Minnesota, when healthcare costs so much out of pocket, when people are struggling to keep a roof over their head, afford their groceries, people end up they're forced into a position of having to make sacrifices for their health. I really want to make sure that when I'm practicing medicine, for example, that I am taking into consideration the full comprehensive picture of the struggles and challenges that my patients face, especially if they're from marginalized communities, including social determinants of health, because I think that has been missing especially at a systems level, but also on the practice level, in our consideration of how do we uplift patients and ensure that they're getting the care that they need. There's certainly still quite a bit of racism in medicine, and there's racism in a lot of our algorithms that we use to assess the standard of care for treating patients. I'll give you an example. Up until a couple of years ago, and this was really based on, the reason this existed was really just based on one not great study that was poorly evidenced from the 90s, but up until a couple of years ago, and this was pioneered at the University of Minnesota, this changed thankfully. If you went and got a kidney function exam or a kidney function lab test, right, it would have what's called a glomerular filtration rate, GFR, and for most everybody, it would have two lines. It would say GFR above 90 and then GFR above 90 if African American. Now, as we know, there is nothing biologically that separates any of us from one another, regardless of the color of our skin, right? So that's an example of racism that has persisted in medicine that thankfully the University of Minnesota really spearheaded to say, no, we shouldn't have different lab values just assigned based arbitrarily on race, and that has harmed so many.
That are not based on science.
Excuse me, yes. We cannot have lab values that are not based on science, and lab values that take into consideration race in any context end up resulting in, especially for a lot of black folks, them not qualifying for dialysis or kidney transplants in the same way that other folks would. So, I'm glad that we're starting to make that change, but there's still so much work that needs to be done to work to educate future providers and current providers against racism in medicine.
Hunter, we're down to our last 2 minutes. I want to ask you real quickly, if I could. You have received, you're going to be doing something called MetroPAP.
Yes.
And it's quite an honor, as I understand it. Tell us about that.
Yeah, so MetroPAP, or the Metropolitan Physician Associate Program, is a longitudinal clerkship that I'll be doing for my clinical rotations that focuses on serving underserved and marginalized communities. I'll be at a clinic in Minneapolis, and learning how the social determinants of health, all these different factors, access to food, access to, roof over your head, the environment in which you live, access to transit, all come together to form the composite of people's health. So, when I talk, I'm very passionate about eliminating racism and working to eliminate structural racism in medicine. And this is one step that that I'm very grateful that I get to take to begin to learn how to practice medicine that really uplifts the needs of all of my patients, especially those who have been left behind from our medical apparatus.
Mm-hmm. Quite an honor. Congratulations.
Yeah, thank you.
I think that's great. And just knowing you and I, we were discussing before the program began today, we've known each other almost a decade, nearly a decade. And from the very first time I met you, I've been impressed by your passion, your intelligence, and your commitment to anything that you undertake, whether it was beating cancer, running and winning a seat in the Minnesota Legislature, securing a spot at the U of M Medical School. So I certainly wish you all the best in your continued studies. And I look forward to having you on the show again. And someday I'll be introducing you as Dr. Hunter Hunter Cantrell, excuse me. Hunter Cantrell.
Lot of hunters in the news.
Yeah, a lot of hunters in the news. don't know where that came from. Dr. Hunter Cantrell someday, so that'll be a great thing.
Looking
but
forward to
best
it.
of luck to you in your studies, and thank you for being our guest today again on Access to Democracy.
Thank you, Steve, and thank you to your viewers.